Okay, guys, welcome to the last session here. I know it's been a long day. We'll ended up with a spine trauma case. My name is Nader Dahdaleh. I'm an associate professor and spine surgeon at Northwestern, and we'll be speaking about a spine trauma case here to end this beautiful morning for this spine symposium. So this is a 19-year-old man who was intoxicated and suffered a rollover car accident requiring extrication. The EMS came right away to the patient and to the side. They placed the patient on a board, spinal precautions were maintained, and the patient was transported to the emergency room, specifically to the trauma bay. Now, usually in level 1 trauma centers, the trauma team will be waiting for that patient to come. Moreover, sometimes the neurosurgery resident or faculty, they get the trauma activation page, and they also go to the ER waiting for that patient just to make sure that patient does not need neurosurgical attention. So this patient arrived to the trauma bay, and let's say you're called upon to see the patient, and what do you want to do? So first thing that you need to do and not forget about, any patient with a polytrauma, think about the ABCs, airway, breathing, disability, environment first. So you got to check out the ABC box first. Usually the trauma surgeon is there to do that. And what would they do? They'll make an assessment on the airway, breathing, and circulation. Before you start delving into the injury and finding where the injury is and how to fix it, you want to make sure that the patient is not suffering from a life-threatening condition, an internal bleed, or the patient is choking because of an obstructive airway. So you check that primary survey first. How do we do that? So we make an assessment on the vitals, and let's look at the vitals. The blood pressure was 118/72, heart rate 90, respiratory rate 22. He was saturating 98% on room air. Quickly, does these numbers look okay to you?
So there's an increased respiratory rate.
It's a big increase, commensurate with pain, but is the patient, otherwise the patient's vitals are stable, right? So we're happy with that. A quick blood draw shows that the hemoglobin hematocrit 1442, white count 9,000, chemistry normal. Does that look okay?
There might be some kind of hemoconcentration, or is it?
That's within normal ranges. So usually what we're looking for here is like a drop in hematocrit hemoglobin, like 7, that would make you concerned about like an active bleed. And that was not the case. So far, the ABCs are checking out. The trauma team completed their primary survey with no intervention. So always think when you see a patient with polytrauma, ABCs first, before you go into, our role comes into assessing the patient's neurological condition and mental status. So with a neurological exam, which comprises the disability component of the primary survey. So this is the patient's neurological exam. The patient was awake, oriented to time, person, and place. His cranial nerves 2 through 12 were normal. His motor power showed the following. His deltoids were 5 out of 5, biceps 5 out of 5, triceps 2 out of 5, and his hand intrinsics were 0, and his lower extremity exam was 0. So it's a drastic exam. So he could not move his hand intrinsics and his lower extremities. Had some weakness in the biceps and the triceps. His sensory exam 2 showed a sensory level at about C7. So he could sense his shoulder, proximal arm, a bit of his distal forearm, as well as the thumb and index fingers, but nothing else. So that would put him at a sensory level of C7. He was hyporeflexic in the upper and lower extremities. So a neurological exam is important. Why? Because it would localize the lesion. So a history is important, but a neurological exam is important in localizing the lesion, which is the cornerstone of neurology, neurosurgery, and neurosciences, is to localize the lesion. Where should we image? Where is the deficit? In the neuro axis, brain, cervical, thoracic, lumbar, peripheral nerve. Where is the deficit in that neural axis? So where do you guys think the lesion is? Is it in the brain, brainstem, cervical spine, thoracic, or lumbar, based on this exam?
Probably cervical spine.
Mm-hmm.
Excellent. It's in the cervical spine. The patient has upper and lower extremity weakness. So it should locate somewhere in the cervical spine. Let's say added to that, the patient had absent gag cough and he had an issue with his oculomotor power or loss of facial sensation. Where would you localize the lesion?
Brainstem.
Brainstem. Excellent. Good job. So this lesion localized to the cervical spine, and hence we want to image the cervical spine. Now, in a patient with polytrauma, second nature, usually a patient with polytrauma, suspected cervical or brain injury, they automatically get a head CT. So here we're localizing the lesion to the cervical spine. What imaging we want to order?
I have a quick question.
Sure.
When you said there's numbness, is it like both sides numb to pinprick, or it's one side?
Yeah, both sides. Both sides.
Okay.
Both sides symmetrically, perfectly symmetrically. Yep.
Thank you.
Sure. So localize the lesion. What imaging do you want to order? We got a head CT, obviously, with any polytrauma case, but more importantly, a CT of the cervical spine, which is the gold standard. Why is the CT a gold standard and not an X-ray? Let's say can we get an X-ray of the cervical spine, AP, lateral, obliques, open mouth? Is that adequate? The answer is no. Why is that? Because an X-ray of the cervical spine would miss lower cervical injuries and upper cervical injuries. For example, if a patient has a fracture involving the occipital condyles, this may be missed on an X-ray. More importantly, if a patient has OC dissociation, where the bones are normal, but the occiput is displaced or dissociated from the cervical spine from C1, then that can be missed. And missing that is a disaster, because these patients, if they're intact, any movement would cause them to become quadriplegic because of the inherent significant instability of this injury. Also, we may miss an injury involving the lower cervical spine or upper thoracic spine with an X-ray, because the shoulders are in the way. Okay, so we get a CT of the cervical spine. Now, oftentimes patients with, let's say, a cervical spine fracture may have another fracture elsewhere in the spine, but they're not paying attention to it because of the significant pain and morbidity because of the index injury. They may not report thoracic or lumbar area pain, and hence we still image them because we want to rule out concurrent injuries. We do that either with thoracic or lumbar X-ray, or we get a CT of the chest and pelvis, which is usually part of the trauma protocol. So already, when you see those patients that already have a CT of the chest and pelvis, which can image and includes imaging of the thoracic and lumbar spine. Okay, let's look at the cervical spine CT. And who wants to take a crack at this?
Looks like a dislocation of C6.
Good. So let's look at this. So this is a mid-sagittal view. These are parasagittal views. And excellent. The first thing you look at is the spinal alignment. And look at the spinolaminar line here. You look at this here. It's really good and smooth. And then it gets disrupted here. And you can see here, there's a dislocation or malalignment. Looking at the parasagittals at C2, 3, 4, 5, you can see here how the facets are well aligned here. See 3 over 4, 4 over 5, but then you can see that this facet is displaced over this one, C5 over C6 on both sides. So we call this bilateral jumped facets. And that's how it looks like on the axial view. Bilateral jumped facets or a fracture dislocation is the diagnosis. Does this image explain the patient's symptoms?
I have another question, if you don't mind.
Sure.
Why is it dislocation and not subluxation?
It's the same. Fracture subluxation or fracture dislocation.
Okay, thank you.
Semantics. Yeah, sure. We usually say fracture dislocation more commonly. I mean, so
it does.
It does, correct. So yeah, this is definitely a significant injury and explains the patient's Asia A injury, complete spinal cord injury at C7 or C8. So this is a fracture dislocation. Now we're going to digress here for a moment to speak about a very important principle. When you see a patient with a spinal fracture, we need to make an assessment as to whether the fracture is stable, which means it may heal with a neck collar, rigid collar bracing, or a crown halo vest bracing, or an unstable fracture that would heal, that would need internal fixation and stabilization. And this is an important distinction. That's where our role comes into play, assessing patients' spinal stability. Why is that? Because if you treat a patient with an unstable spine without an operation, you treat them with neck collar bracing or with a crown halo vest, their neurological insult will cause worsening deficit, disability, deformity, and the fracture won't heal. So that's why you don't want to miss on an unstable injury. And there are ways that help us guide, make that assessment accurately. So here we're digressing. The best individuals who defined what constitutes clinical stability or clinical instability of the spine are Punjabi and White. Punjabi and White, a biomechanical engineer and also a surgeon. And they put forth an important book. It's Clinical Biomechanics of the Spine. The first edition, 1978 or 79. The second one was 1990. Is a major reference on that we refer to when we want to study spinal biomechanics and understand the importance of different structures in terms of range of motion and different approaches in terms of biomechanical spinal stabilization and implants. So what did they say about spinal instability? A stable spine is a spine that under physiologic loads is free from deformity, neurological deficit, and or pain. So a stable spine is a spine that is under physiologic loads, free from deformity, pain, and or neurological injury. Okay. Over the years, there have been many different classification systems. Initially, these classification systems were more descriptive, but more recently, they were more important because they did not only describe how the fractures look like, but they help guide treatment plans by helping treating physicians, surgeons, make an assessment as to whether the spines are stable or not. One of the most important classification systems mainly applied for thoracolumbar fractures, not for the cervical spine, but we can extrapolate just the 3-column model of this classification system to the cervical spine, is that by Denis. So Denis put forth the 3-column model for spinal fractures, and the 3 columns that comprises the vertebrae are the following. The anterior column spans the ALL, anterior longitudinal ligament, to the mid-vertebra. The middle column is the mid-vertebra to the PLL, posterior longitudinal ligament, and the posterior column comprises the posterior elements, which include the pedicles, facets, lamina, spinous processes, and transverse processes. Now, in general, if there's a fracture that involves the anterior column, we call it a compression fracture. And the force vector creates a compression force vector to create that fracture. Axial loading will cause what we call a burst fracture. Fracture of the anterior and posterior columns, a fracture of the anterior and middle columns. Sometimes you have retropulsion of a fracture fragment into the canal, which may cause a neurological insult. So anterior middle columns equals burst fracture. Fractures of the posterior column and the middle column create what we call a flexion distraction injury or a chance fracture. Fractures of all the columns create a very unstable state, which may cause a flexion distraction injury or a fracture dislocation. Another important point to simplify treatment, the treatment thought process is most, if not all, anterior column injuries or compression fractures are treated non-surgically with bracing All 3-column injuries are unstable injuries. Fracture dislocations or flexion distraction injuries are treated with spinal stabilization. The question is how to treat burst fractures. These we need to look at other criteria other than the morphology. You also include the integrity of the ligaments and the neurological state. Now, in order to aid in the decision-making on how to classify a fracture as to whether it's stable or unstable, a very important classification system that's robustly used in North America is the subaxial injury classification scale, which looks at 3 criteria: morphology with the CT scan, compression, burst, fracture dislocation, flexion distraction. The second criteria is the integrity of the disco-ligamentous complex. If they're intact, you give a score of 2. If they're disrupted, you give a score of, if they're intact, you give a score of 0. If it's disrupted, you give a score of 2. And the neurological status. Patients who are intact receive a score of 2. Patients with a complete injury, 2. Patients who are intact receive a score of 0. Patients with a complete injury score of 2 and incomplete injury score of 3. You add these up, and then you come up with an injury score. If it's more than 4, it's unstable. You treat it with a surgery. If less than 4, it's stable. You treat it with bracing, be it rigid collar or crown halo vest. Patients with a score of 4, you can treat them either way. So let's go to our case here. These are the ligaments that that are included in the classification system: ALL, disco-ligamentous complex, PLL, and the posterior ligamentous complex that comprise the facet capsular ligaments, ligamentum flavum, interspinous ligaments, and supraspinous ligaments. Back to our case. So we have the neurological exam has a deficit, and we have this fracture morphology, fracture dislocation. What is left to make an assessment as to whether the ligaments are disrupted? What imaging should we get to make an assessment on the integrity of the ligaments?
MRI.
Correct. So this is the MRI. These are sagittal cuts, and that's an MRA to look at the blood vessels. This is a sagittal cut that shows the fracture dislocation, and you can see here kinking of the spinal cord, compression, and also spinal cord edema here, some swelling. This is a stir signal that gives you a better assessment on the integrity of the ligaments. Not surprisingly, the patient's ligaments are torn front to back or back to front, creating a condition of what we call total segmental disruption. The ALL is disrupted, the disco-ligamentous complex is disrupted, the PLL is disrupted, ligamentum flavum, capsular ligaments, supraspinous ligaments, interspinous ligaments and supraspinous ligaments are disrupted. We oftentimes get, or universally get actually, an imaging that looks at the blood vessels of the neck, because sometimes these patients with significant trauma to the neck may have an associated vascular injury, be it a carotid dissection or a vertebral artery dissection. So now we have the complete picture to make an assessment on whether or not the patient has an unstable or a stable injury. Who wants to do the math? Who wants to do it? Okay, I'll do it. So this patient has a fracture dislocation, gets a score of 4. His disco-ligamentous complex are disrupted front and back, gets a score of 2, so 6 total. And the patient has a complete spinal cord injury, gets a score of 2. Total is 8. So 8 is more than 4. So clearly the patient has an unstable injury. Clearly the patient needs surgical stabilization. Okay, so now the next step is, we made an assessment that this patient needs spinal stabilization. The next step is to how to go about that. And this you will definitely learn, when you become residents and you see a lot of patients and then see the approaches and that we use to stabilize the spine. And you'll gain that with more experience. So this patient has a fracture dislocated. So his dislocation is kicking the spinal cord. In addition to the forces that created the injury that caused the spinal injury, the deformity is contributing to the compression. So when you see a patient with a dislocation, you want to always reduce those patients or attempt to reduce these patients into their normal alignment. By doing that, you're decompressing the spinal cord already. And then you stabilize the spine. So you always want to make an effort to relocate a dislocated spine. How do we do that? We do that by placing them in crown halo traction. Okay, so this patient, the trauma bay, was placed in a crown halo traction apparatus, and that comprises of crown halo. You put it on, and then you fixate it to the skull with 4 points of fixation, two anteriorly and 2 posteriorly. You choose the anterior points of fixation such that they coincide with the point of intersection of the equator with the midpupillary line. And the posterior points of fixation is somewhere at the level of the parietal or parieto-occipital area. You put those pins, you tighten them to 8 inch-pounds or 0.9 Newton meters. You attach the bale and then rope pulley system, and then you attach the weights. And you're trying to pull the head and the cervical spine and attempt to realign the spine so it looks so we can achieve a normal anatomical relationship here. So we place this patient in traction, and the principles are, in terms of how much weight we can add, the upper cervical spine or occiput C1, C2 can tolerate up to 15, 20, maybe 25 pounds. And then each disc segment, you add 5 to 10 pounds per segment. So we place this patient, we pushed it a little bit. We placed him in about a maximum of 57 pounds of traction, and he started saying, my neck hurts even more. So the question is here, did we achieve our goal of relocating this dislocated spine or not? Who's going to answer that question? Did we achieve the goal?
No.
We didn't. So, okay, we didn't. That's okay. At least we made an attempt. So now we need to proceed with surgery. Now, in patients, invariably, in patients who we didn't achieve the goal of reduction, we have to approach them posteriorly most of the time. Why? Because we need to drill the superior articular process here, the SAP, such that the inferior articular process will fall down to where it's supposed to be. And then we do the fusion by placing screws and rods, lateral mass screws and pedicle screws. And we usually do that with long segment fixation, not a short segment, long segment, 2 above or 3 above and 2 below the index level of injury. So we did that. Actually, we took the patient to the operating room. Even before making a stent incision and drilling the superior articular process, the patient was placed in pins. He was placed prone. And then with the induction of general anesthesia and neuromuscular blockade, he relocated appropriately, even before drilling the SAP, which was good. We did the surgery. We placed the screws above and below the fracture, C4, 5, and 6, and then T1 and T2. Everything went smooth. We did the decompression too, above the level of injury to give room around the spinal cord because we know it's going to swell. So now this patient post-operatively was extubated, and he maintained his preoperative exam. His deltoids 5 out of 5, biceps 5 out of 5, triceps 3 out of 5, or 2 out of 5, and 0 in the hand intrinsics. Now something happened to this patient. Post-op day 3, you're rounding, and you see that this patient who was extubated had an increase in the work of breathing. He was breathing difficultly, labored breathing. His heart rate was 120. He was tachypneic. His respiratory rate was 35. Was difficulty breathing, and he also, when you examined him too, could not move his deltoids or biceps. So he lost, or triceps too. He lost his post-operative exam. So what do you want to do at this stage? You have this change in the neurological exam. So first of all, yeah, go ahead.
Take the images again.
Exactly. So want to image. But before doing that, if you see a patient who is not protecting his airway, and the patient was intubated so that the air was protected so that you can obtain the imaging safely. So he was taken down to an MRI. And why do we want to image him? Because we want to make a diagnosis. Yeah, what do you want to rule out?
Epidural hematoma.
Exactly. So we want to rule out an epidural hematoma. That's what we're thinking about. And number two is we want to rule out other things. So this is the image. That's a sagittal T2. This is sagittal T1, and that's a GRE sequence. And you can see here there was no epidural hematoma pushing on the spinal cord, but what we noticed that he had extensive spinal cord swelling, tracking up to the upper cervical spine, actually to the caudal medulla. So that explained the patient's deficit, his work of breathing because of the upper cervical spine involvement, and obviously the also explained his weakness. So it was spinal cord swelling. You see that in the brain. You do an hemicraniectomy to evacuate subdural hematoma, then the brain swells. Peak swelling is about 48 hours after the insult, and that's what happens sometimes in patients with spinal cord injury. But always we want to make a diagnosis. If there's an epidural hematoma, you're going to take them back to surgery and remove the extrinsic pressure that the epidural hematoma is causing. But if it's an intrinsic issue, then you can't manage that with an operation. All you can do is keep the blood pressure adequately perfusing the spinal cord, keep the maps up, drive them up to 90, 95, and also you can give them some steroids in an effort to mitigate the spinal cord swelling. And that's what we did. Now here, I want to mention a couple of things that I forgot to mention initially. It's imperative to keep the maps up. The moment you see patient with spinal cord injury in the ER, you want to make sure the patient does not suffer a hypotensive episode that would result in further insult and secondary damage to the spinal cord. And that works. So, and then the other thing is to operate on them as soon as possible to give them the best chance of a neurological improvement and or recovery. The only two things that stood the test of time and are supported by evidence-based medicine, is early surgery and keeping the maps up for patients with spinal cord injury. Other interventions in terms of metabolites and drugs and cooling are not as effective as these two. So the evidence is supportive of these two things and these only two things. So this is the patient's images. He was ultimately had the tracheostomy placed, and then ultimately was discharged to LTAC and then rehab. He improved. He regained 2 levels of motor function. He could move his hand intrinsics a little bit, which is extremely meaningful and important for these patients because they can navigate now a wheelchair. They can transfer. So any motor level that they gain, let's say if it's a C5 motor level to C6, C6 to C7, C7 to T1, anything that they gain, it goes a long ways in terms of the rehabilitation and in terms of day-to-day functionality. Here I end my talk, and if you have any questions, please feel free to ask.
Dr. Dahdaleh, so I have a question regarding the usefulness of the AO spine classification regarding this management.
The AO spine is very useful. It's robustly used in Europe. To me, it's more descriptive. It is a very detailed, impressive, detailed description of every single possible fracture in the spine, cervical or thoracic or lumbar. So it's an elaborate description, but it does not necessarily guide you in terms of management or in terms of assessing scoring, assessing as to whether the spine is stable or unstable, as much as the TLX. That's in my view. It's more descriptive, definitely much more descriptive than the TLX. And this is important because when we're communicating with each other, you know, it's easier to say you have a fracture, a B2 fracture, you know, than a TLX score of 3. You know what I mean? So in terms of communication, describing of what the fracture is definitely more useful than the TLX. The TLX is more useful in terms of management. So there's no one fantastic classification systems. All are great, but you need to put them together and to make them all useful.
Thank you.
But it's definitely an elaborate, detailed fracture classification system that describes every single possible fracture. Sagittal split, pincer fracture, you know, it's very descriptive. And this is important when you communicate, you know. Okay, thank you guys for joining us and my colleagues this morning. And I thank also the Brain and Spine group for putting together a beautiful, beautiful symposium today.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.